Assuming there are 100 people in the room right now and everyone is diabetic, how many of you will become a statistic by losing a toe, foot, or leg because of a diabetic wound? So the actual correct answer is 14 to 24 people out of 100 will actually be a statistic by losing a toe or a foot from being diabetic. What percentage of people will develop diabetic neuropathy? The correct answer is 50%. All right, so what we're going to do is we're going to turn it over to Dr. Biggs right now, who is going to talk to you about diabetes and diabetic wounds.
I'm a family practice physician at Arcola. Also, I'm working now at the wound clinic here at Advanced Wound Care up in the hospital on the 3rd floor. And so I want to talk about diabetes and wounds. Now, as you can see there, diabetes has a huge impact on your body's ability to heal wounds. And so having good control of your sugars is very important. So kind of talk about that. How does it interfere with your body's ability to heal? First part there is diabetic neuropathy. As that one slide showed, that over 50% of patients will have some form of diabetic neuropathy, which is basically the cause of it isn't really well known, but your body's nerves are affected, and so your body just does not sense that there's been any damage done to your skin, any sore, pain whatsoever. It just interferes with that ability to sense that. So over time, you can have an injury that starts off very small and you don't know anything about it, and you continue to have the damage to it over and over and over, and then eventually it becomes something huge. You might start noticing a bad smell, and that's when you look and see, oh, I got this huge ulcer on my foot. Also, how does diabetes affect your wounds? It limits your body's ability for blood flow. Just like the high blood sugar can affect the nerves, it can affect the arteries as well. So the small blood vessels that carry the blood, far away to the skin, kind of affects those, damages those, so then they're not working quite as well, and therefore you're not getting the blood to the skin, and that wound cannot heal. Another issue there is that high glucose levels can interfere with protein synthesis, so then your body can't make the proteins that are necessary to, again, heal those wounds. So one of the big things that we see in the wound clinic are diabetic foot ulcers, which are very problematic. Diabetics have a 15 to 25% chance of developing a diabetic foot ulcer. And then once you develop a diabetic foot ulcer, 85% of the time those proceed onto a limb amputation. Not necessarily right away, but eventually those who develop one ulcer, they'll eventually have to have a limb amputation. Study showed about 85% of the time. So the benefits here at the Advanced Wound Clinic, we have nurses and then providers and then staff that can work together to provide an integrated approach to help you with these wounds. We have more supplies available to us and different modalities that we can use to help you heal that wound. Our goal is within 16 weeks to get that wound to heal 100%. Like we kind of talked about those different modalities, what could they be, different dressings that we can apply on top of the wound, skin substitutes, if we do different debridements, sometimes manual debridement with a curette, sometimes that's using your body's own enzymes to do that debridement, and other ways of working on trying to increase that blood flow, working with Dr. Donde and the cardiology clinic here to again restore that blood flow. Now this is a gruesome slide here for some people, it might be, but my point in putting this slide up here is this is a patient of mine that I'm treating with a diabetic foot ulcer. Now if you look on the left-hand side there, this is a toe that she presented to me with where she didn't know that she had that big of a sore there. She just thought it was one little spot. After I did a debridement and I opened up the wound and showed her that there on the right side how big that wound actually was. So all that junk around it is just dead callous tissue where she was having continuous pressure on that wound, continuing to shear forces kind of building up that wound underneath the skin that she couldn't see, but the wound was actually that big all along. So that's the importance why we say to check your feet regularly is kind of that point right there, is that we need to keep an eye out for that to make sure that doesn't develop, and if it does, you catch it early enough that we can prevent it from getting that bad. Other wound modalities that we use for diabetic foot ulcers are the hyperbaric oxygen chambers. We have 2 of them up here at Sarah Bush. This is an environment that we have 100% oxygen, and we increase the pressure, and it gets the blood to go further into the tissues when those blood vessels, like we already talked about, aren't working quite well. That it gets that blood and oxygen a little bit further into the tissue so that wound can heal.
What are the 2 best things a person can do to delay or prevent type 2 diabetes? So the correct answer is number 2, which was exercising regularly most days of the week and losing 5 to 10% of your weight. What is the leading cause of death for people with diabetes? So the correct answer is actually cardiovascular disease. All right, we're going to move on to our next presenter, Paula Enstrom, registered nurse and certified diabetic educator.
You know, a lot of people don't realize that there are things that can be done early on before you're actually diagnosed with diabetes to help prevent becoming diabetic. There have been several large studies that have shown that people who are pre-diabetic, which means that their blood sugars are running a little bit high, but not high enough to actually be considered diabetic yet, if they exercise 150 minutes a week, so that's a half hour, 5 days a week, and lose 5 to 10% of their weight, they can reduce their risk of diabetes over 5 years by 58% and over 10 years by about 1/3. That's huge, because when we talk about diabetes and complications of diabetes, the longer you live with diabetes, the more poorly it's controlled, the greater your risk of complications. So if I can delay it by 5 or 10 years, that's a huge thing. What's also huge about that is most people that we talk to today, I mean, if you look at the slide up here, it shows how our weight in America has been increasing on the top. The darker the colors get, the more obesity we're seeing in the United States. The bottom is the darker the colors that we get, the more diabetes we see in the United States. As America has become heavier and heavier, we have a lot of people that need to lose a lot of weight to reduce their risk of diabetes, but they're overwhelmed by the idea of losing 50, 70, 100 pounds. And what they don't understand is it doesn't take that to make the complete difference. A little bit of change can make a big difference. And if we can get that word out and get people making a little bit of change, if you weigh 300 pounds and I say to you, if you lose 15 to 30 pounds and exercise a half hour, 5 days a week, it can help to reduce your risk of diabetes dramatically. That's something that people might be able to do. On the other hand, if I say you gotta lose 150 pounds, they're just gonna throw up their hands and say, I can't do it. So I think we need to get that message out there. As far as cardiovascular disease, I do wanna hit on that a little bit, because cardiovascular disease is the #1 killer of people with diabetes. Over 50% of people with diabetes will die of a heart attack or similar heart condition. Many more will die of stroke. About 2/3 of them will die of one or the other. A lot of people don't realize that. And so when Cindy talks, I'll leave this to the dietitian, but everybody thinks about carbohydrates and how many carbohydrates I need to eat, but you also have to look at what you're eating as far as your heart risk goes. So I have people who are diabetic and say, I can eat all the bacon I want because it has no carbs, but it's full of fat that will clog your arteries. The best thing you can do as a diabetic, and it's the hardest thing to do, is to take little steps to gradually improve your lifestyle. And it's not something that just diabetics need to do, it's something that we all need to do. I've been doing diabetes education here at Sarah Bush for about a dozen years. I was doing it prior to that. What is amazing to me is I started a diabetic prevention program 10 years ago. And back then, the statistics said that 5.7% of Americans are diabetic. They've just upgraded it. It's now 9.3%. And the CDC just came out with a prediction that 40% of Americans will become diabetic in their lifetime. We have a problem. We're here to help you figure out how to handle it. But one thing that's really important to know is if you have it, the chances of family members getting it is higher too. And so you are setting the example for the next generation and the next generation. So anything we can do to help you take better care of yourself and to learn how to manage your diabetes that you can pass along to the next generation will hopefully make a difference.
For every 1 point drop in hemoglobin A1C, such as an 8% drop to a 7% drop, my risk for diabetic retinopathy drops by what percent? So the answer is 35%. So for every 1 point drop in hemoglobin A1C, your risk for diabetic retinopathy drops by 35%. What percentage of people who have been diabetic for 10 years or more will have retinopathy? Correct answer is actually 80%. So if you have diabetes for more than 10 years, 80% of people will develop some form of diabetic retinopathy.
One of the things when patients come to see me and they're diabetic, one of the things I usually tell them is I'm going to kind of give you my little diabetic spill. And oftentimes I kind of get this sigh like, oh, he's going to preach to me again about watching my blood sugar, making sure my blood pressure is okay and that sort of thing. And that's not exactly how I like to go about it. I like to try to present it in a way that may give you a little bit better understanding of why you're seeing me, what I can do to help the rest of your management team. And I get told a lot that you tell things in such a way that I haven't heard it before. So I'm going to kind of give you that little spill, and then go through it and hopefully be able to answer some questions, maybe simplify things in a way that maybe you haven't heard of. So obviously, diabetes being a disease where the sugars in the bloodstream are high, as those sugars float through the bloodstream, they cause changes within the walls of blood vessels. They lead to those blood vessels becoming hard and becoming narrow. And when that happens, the hardening and the narrowing of the arteries, it's not carrying as much blood. And if you're not carrying as much blood, you're not carrying as much oxygen to your tissues. And in the back of the eye, just like everywhere else, the tissues need oxygen to survive. When I dilate your eyes and look in the back of your eyes, I actually get to see blood vessels. The heart doctors and kidney doctors, if they want to see blood vessels, they'll inject some dye into your veins, take some pictures, and kind of extrapolate from that. Well, I actually get to look in and see those blood vessels. So what we're looking for in the back of the eye in early changes of diabetes, you just have little out pockets of the vessels that we call microaneurysms. That's where the walls of the blood vessel have gotten weak. You can get actually areas of those blood vessels that kind of break open and they bleed or they leak fats or fluids into the retina. The retina is kind of the film in our camera. It's how we see. So if we get anything within that substance, the retina swells up and our vision becomes blurry. If the blood sugars in those kind of stages, most of the time that can be completely reversed just by changing your habits, your activity level, you're watching your blood sugars better. But if you ignore it from there, it only gets worse. And if the eye gets starved of so much oxygen, what will happen is it will actually grow new blood vessels to bring more blood to the back of the eye, which sounds like a divine idea. However, those new blood vessels are quite destructive. They're damaging, they leak, they bleed significantly. They can cause the retina to be pulled off and detached. And it's the more severe case of the diabetic eye disease called proliferative diabetic retinopathy. And with diabetes being one of the leading causes of blindness in the United States, it's usually from that proliferative stage, where proliferative meaning new blood vessels have grown. So the important thing I tell my patients is when I see changes in the back of your eye, although you're here seeing me for your eye, those changes are not limited to your eye. They're going on everywhere in your body. Those are just the blood vessels we get to look at. So if you think about it, lack of blood flow, lack of oxygen, those things lead to early heart attacks, early strokes, and so it all kind of connects. If you see the connection between the blood flow and the eye, it actually connects to the rest of the body. So if we go to the next slide, we're going to take a look here. The picture on the left is a picture of a normal back of someone's eye. That little white round circle is the optic nerve, and you can see the blood vessels that branch off of it. There's a dark spot in the center, that's called the macula. That's where our center of vision is, and that's where we get our fine detail vision. Now, on the drastic picture on the other side is a example of proliferative diabetic retinopathy. As you can tell, those two things don't look nearly alike. The one on the, I'm getting confused. The one on your right it has blood vessels that are very dilated. Those real thick vessels at the top of the screen, that is actually the veins that are having trouble carrying blood back to the heart. The yellow stuff that's scattered throughout the center of the picture is fats that's leaked out of the bloodstream into the retina. And then there's lots of bleeding in other places, some new blood vessels that have grown. And so this is a very severe case of diabetic retinopathy. If we go to the next slide, what we have here is just a couple examples of treatment. So treatment varies very much depending on the level of change in the back of the eye. If there's just a little bit of change, we're going to watch it closely, and I'm going to ask you to pay attention to your blood sugars and especially your hemoglobin A1C. If it gets more severe, we have to do some treatment such as lasers. If you see all the little white spots scattered in the left picture, that's an example of laser that we do for the back of the eye. One treatment involves a minimum of 1,200 laser spots to the back of the eye. The picture on the other side is showing some of the newer ways that we treat certain complications from diabetic eye disease, which is injections of medications into the back of the eye to help with some of the swelling and the leaking. The problem with both of these treatments is that they're not going to be everlasting if you haven't made the changes in your routines that you need to make. We'll go on to the next slide. So what can you do to prevent it? Well, Paula probably had the better answer, but in my opinion, being active in your management is very important. Know your hemoglobin A1C, and if you don't know what the hemoglobin A1C is, it's a 3-month average of your blood sugars. It's kind of tells how fast the train is headed in one direction is the way I look at it. So I'll often ask patients, what's your hemoglobin A1C? And they say, well, I don't really know, but my blood sugar was 127 this morning. So, okay, well, that just kind of tells me what you had to eat before you went to bed last night. But what the A1C is a big deal. And the reason it's a big deal is because in ophthalmology, we did studies that looked at who's going to go blind from diabetes. And the best correlation we had was with the hemoglobin A1C. It found that if your hemoglobin A1C is less than 8%, that your risk of blindness goes significantly down. Now, that's not to say that 7.8 is as good as 6.8, because it's not. The risk continues to go down. But above 8%, the curve for going blind gets extremely steep, and it's very important. In my practice, I consider it the most important number that I'll ask you, because it lets me know how you're doing. So other than that, follow the advice of the rest of your diabetic team, exercise, and see your eye doctor regularly, because they can help out the rest of your team. Thank you.
When reading food labels, important nutrients for diabetics to consider are what? Number 1, net carbohydrate, sodium, fat, trans fat, and cholesterol. Number 2, grams of sugar, sodium, fat, trans fat, and cholesterol. Or number 3, total carbohydrates, sodium, fat, trans fat, and cholesterol. So when you're looking at a food label, you need to consider all those: total carbohydrates, sodium, fat, trans fat, and cholesterol. All right, second question. How many carbohydrates should a person with diabetes consume per day? So the correct answer is actually 50 to 55% of your intake should come from carbohydrates. So we're going to let Cindy take it from here.
Hello, my name is Cindy Foster. I am a registered dietitian at Sarah Bush for about 30 years. I've been a diabetes educator for a little over 15 years. And diet is one part where you play a very active part on your diabetic team. And what is important with the diabetic diet is that we are consistent with how much carbohydrate we eat. Carbohydrate is the body's chief source of energy. Whether you are diabetic or you're not diabetic, carbohydrate is still the only effective good energy source for the body. So to meet our body's carbohydrate needs, 50 to 55% of what we eat should come from carbohydrate. What is important when we're diabetic is that we get very consistent with that carbohydrate and the timing of our meals with that carbohydrate. Tonight for supper, you had about 60 grams of carbohydrate, and that was pretty purposeful, okay? That's where a lot of people need to be, especially most of the men need to be at about 60 grams of carbohydrate. Women who are trying to lose weight, maybe just a little bit less than that. And I need to try to divide that evenly throughout the day, because if I usually have 60 grams of carbohydrate for supper and I take 10 units of Novolog insulin, tomorrow what if I want to have 100 grams of carbohydrate for supper? But I still only take 10 units of Novolog insulin. Our goal as diabetics, and your challenge as diabetics, is to get consistent with your carbohydrate intake. Because until I'm consistent with what I do every day, it's very hard for our physicians like Dr. Biggs to regulate our medicine, because every day I eat differently. And in order to help our physicians regulate our medicine, we need to be consistent with what we eat, and then that allows our doctor to be able to see where we are routinely. So don't cut all the carbohydrate out in your diet. Yes, Americans eat too much carbohydrate, and I'm sure that most of us have some that we can find that we can cut out. But we don't want to cut it all out. We want to be consistent. We don't want to, a lot of people, breakfast we can hit or miss, lunch we work through, and we eat everything from the time we get off work to the time we go to bed. We can't do that, okay? We can't put all that carbohydrate into our bodies at one time, but we need 3 balanced meals a day. You need breakfast, you need lunch, you need supper, and you need to be consistent with the amount of carbohydrate that you eat. And that is kind of, as a diabetic myself, that's kind of our role, okay? That's kind of our challenge, is to be consistent with what we do, and that will help enable our medical team to be able to do things like adjust our medicine and things for us once we are consistent.
Either one, it depends, I guess you would say, on how tight control you have with your diabetes. Type 1 diabetes is still going to have elevated glucose, just like a type 2 diabetic could have elevated glucose, and it's going to interfere with that. It depends. Type 1 diabetics over time tend to have more issues with their blood vessels and their nerves as well. But a type 2 can very well be just like a type 1 with that. In that regards, it depends on a type 2 diabetic that does a good job controlling their sugars, then they can really manage that fairly well. Hopefully that answers enough to say it just depends on how well you do controlling your sugars.
What we really want to look for on the food label is total carbohydrate, because the Atkins food label wants to do things like take the total carbohydrate and subtract the sugar alcohol and then give you a net carbohydrate number, but that's not really endorsed, okay, in diabetic circles, because what they say is you can't really subtract all of that sugar alcohol. You can maybe subtract half of it. So it's really kind of more important to look at that net carbohydrate. If there is a high sugar alcohol content, you could subtract half of it. And that's what makes it so challenging, I think, to be diabetic, because those things are really confusing. But the total carbohydrate is the number that you really want to focus on.
Well, it all depends on age as well, but to diagnose diabetes, 6.5 is what you need to have to diagnose or be diagnosed with diabetes. Now, once you have diabetes, your number might vary what your physician wants you to target or where you want to be at. There's been some studies of very tight control, and maybe the elderly population isn't as good for the patient as far as outcomes. And so the physician might be more willing to have your A1C between a 7 and 8. But for younger patients, they would like it below 7.
It absolutely can. It depends on the stages. I mean, one of the things I didn't show you were the different stages of diabetic retinopathy. And you can think of it as kind of a mild, moderate, severe, and then proliferative, which is terrible. So in the mild and moderate stage, absolutely. Most of the time I will, instead of seeing patients on a 9 to a 12-month basis, I talk to them about changing the habits and lowering the blood sugars and lowering the A1C, see them back in either 3 to 6 months, depending on the stage, and watch some of these things go away. It's been very gratifying at times as a physician to have those talks with patients and then 6 months later come back and have changes completely gone in the back of the eye, and I didn't do anything. The patient did it all themselves. And so it is reversible in its early to moderate stage. After the eye has been starved of oxygen or for a long period of time, that's you start getting into the more severe stages, and that's when it becomes we have to intervene with some form of treatment. But early and moderate changes, absolutely, you can reverse without me doing anything. The easiest answer is to tell you is at least once a year, and from that it can be guided. Now, it changes a little bit. If you're a newly diagnosed type 1 diabetic and you're a teenager, actually having an exam at the time of diagnosis isn't as necessary as you may think. That's because they're usually they present a little differently when their blood sugars are high, type 1s do, and they haven't been diabetic as long. And a type 2 diabetic patient has oftentimes been diabetic, or at least pre-diabetic, for 5 to 10 years before it's been brought to their attention. And so for a type 2 diabetic, you should have a dilated eye exam at the time of diagnosis and then every year from there on. So.
That's really individualized. When somebody comes in, what we usually do is take a little in-depth diet history, calculate your calorie needs. It's a formula based on your carbohydrate, it's based on your age, your weight, your height, your activity level. They usually recommend, around that 50% of calories to maintain ideal weight. So we may subtract a little, and there's a formula that is actually used to calculate that individually. But there definitely is a thing is not enough carbohydrate, and there are a lot of really low carbohydrate plans. I know at one time the American Academy of Sciences said 120 grams of carbohydrate was minimal for brain function, okay? So going on a, crazy, I've had people say, I'm supposed to eat 5 grams of carb a meal. I'll be like, no, you do need about 50% of your calories from carbohydrate, so we would have to calculate your carbohydrate to go from there.
Type 1 diabetes, they believe, is an autoimmune disease where the body destroys the cells that make insulin, so that there's no insulin being made at all, and in order to survive, you have to take an insulin injection. Type 2 diabetes, and it used to be considered juvenile diabetes or insulin-dependent diabetes, they used to call it, and it can happen at any age, but usually occurs in teenagers, young adults, sometimes in children. Type 2 diabetes is a pretty complex disease, but one of the first things that we see with it is actually that the body starts to not respond to insulin the way it's supposed to. And our body starts to make extra insulin to try to keep the blood sugars normal. And actually, this can happen 10 years before you're diagnosed with diabetes, before blood sugars are abnormal. But it's a combination of insulin resistance, so the cell's not responding to insulin well. So I eat a meal, and my blood sugar starts to go up, and normally I'm not diabetic. My pancreas is going to send out insulin to help that sugar get to where it needs to go and keep my blood sugar steady. Before I'm even pre-diabetic, as I start to gain weight, especially in the middle, my cells stop to responding to the insulin. So when I eat, my blood sugar goes up. My pancreas has to send out extra insulin to keep my blood sugars normal, and it can do that for a long time. And then it starts getting tired. And so then I eat a meal, and my blood sugars go up, and my pancreas sends out as much insulin as it can, and my cells are responding to it even less. And so over time, what happens is the cells that make insulin get worn out, and as that happens and my cells don't respond to it well, my sugars keep creeping up. It also has to do with cholesterol and a whole bunch of other things that are abnormal in it. But the biggest difference is that my body is making some insulin initially in type 2 diabetes, but doesn't make any in type 1. I don't know if does that help?
One thing I'd like to add to that, if I could, sometimes it's very confusing. People know that type 1s take insulin, and they always take insulin. Type 2s can also take insulin. And a lot of people who are type 2 diabetic, if they start taking insulin, think they are now type 1. But that is not true. Okay, type 1 diabetics take insulin. They've taken it from practically the day they found out they were diabetic. Type 2s may take insulin. Okay, they'll usually start out with diet and exercise and maybe several oral medications. But just the addition of insulin into your treatment plan when you're a type 2 diabetic, you're still a type 2 diabetic.
Well, simplified, the stress response, if you think back to way before us, but we'll go to caveman days. What were the stressors in our lives? The stressors in our lives were starving for food, struggling to fight for food, struggling for our lives. It was all physical stuff to try to keep us safe. And so our body adapted to that, so that when we get stressed, our body thinks, oh, physical stressor, I have to give my body things it needs for physical stress. Well, what do I need if I'm stressed? I need sugar to get to my muscles so I have energy to run away, right? I need cholesterol to repair cells if I get caught. My blood pressure goes up, my heart rate goes up. There's a whole slew of hormonal things that are going on, all geared towards helping my body deal with a physical stress so I can survive. Okay, now think of your stress in this day and age. How much of it is survival, like running away from something or fighting? And how much of it is mental stressors? And when we have mental stressors, our body responds in the same way, but we don't utilize all those things up. And so that can make blood sugars go up, it can make lipids abnormal, cholesterol abnormal, it can increase blood pressure, it can do a whole bunch of, it can make us gain weight in our belly, causing more insulin resistance, making our sugars go even higher, it can do a lot of things.
So I would just add to that, so how can you deal with that stress, or what's the best way? Exercise, exercise, exercise. Just like she was saying, what was the body's normal response? It was, you're going to run or you're going to fight whatever was coming after you. And so the same thing, you need to find a way to use up that energy. Plus, it helps you relieve stress. It's a great way to just clear your mind of issues that could be bothering you, whatever it might be.
And isn't it a shame that the holidays now start at Halloween? Seriously, right? And last until
Easter.
Easter. I was going to say New Year's, but I'll go to Easter. And I believe the Halloween candy hit about, August kind of thing. As a diabetic, I have to tell you this. The hard thing about diabetes is it doesn't take a holiday, right? When I go on vacation, I wish my diabetes would go on vacation, and I did not have to pack it along with me, okay? But it doesn't go on vacation, and it doesn't take a holiday. And with the holiday season stretching from now Halloween clear through New Year's or Easter, every day of that cannot be a special occasion, okay, or a reason to go off of our diet. You need to stick to your meal plan as much as possible, okay? That includes counting your carbohydrate. You need to choose those special days and those special occasions and choose them well. And I always tell people, it's not when you're, it's maybe your birthday and Christmas and Thanksgiving, okay? Think of how many holiday things we do, right? And how many holiday parties we do. And if we just cheated every one of those, think of what our A1C level is going to look like 3 months after the holiday period. We got November, December, January. You go get your A1C done at the end of January. That's going to be reflective. And when your A1C is high, you're causing damage, okay? So keep your meal plan in mind. If you're going somewhere where there's food, you take something that you know that you can have, okay? I find one of the hardest things at holidays as a diabetic personally is meal timing, okay? Because meal timing and your medication timing, and together those things are really important. And then it gets to be like Thanksgiving and someone invites you over and lunch is at 2. Well, really, because I eat at 8, 10, or 8, 12, and 5, and that's when I take my medicine. So there are a lot of decisions to make there in terms of what to do with my med and when I should time it. Education is the best way, I think, to arm yourself, to make some of those decisions. But, try to stick with your meal plan as closely as possible. Try to stick with your meal times as closely as possible. Sometimes I just flat out tell people I'm diabetic, okay? Because diabetes does run in your family, okay? So if I have someone in my family saying, here's the divinity, Cindy, do you want a piece of divinity? Right? If I say I'm diabetic, that kind of, sometimes they won't push that, maybe quite so much. And I have many, many people who are diabetic who come to me and say, well, Cindy, my grandma was diabetic and she ate whatever she wanted. When my grandchildren face diabetes, okay, because my dad was diabetic and my mom was diabetic, so there is a chance my children will be diabetic and my grandchildren will be diabetic. And I don't want them to not follow their plan because their grandma ate everything she wanted. Okay, so there's eyes on you at the holidays. Stick with your plan as close as possible. Make those special occasions few and far between.
Well, it all goes back to your red blood cells, and the average lifespan is about 120 days. And they said that looking at the last 90 days, when the red blood cell and the glucose is in the blood, it gets glycosylated, and that's where that part of it comes from. They can look at those red blood cells and see how much sugar has been attached to that red blood cell. And so with that lifespan of the red blood cell, they can say, okay, going back 90 days, they can look to see what was the average amount of blood sugar that's been going on. So it's a blood test, but that's, the basic, trying to give you the basic part of it.
There's all kinds of lists of carbohydrates out there. If you're going to look on the internet, please use a reputable source, something like the American Diabetes Association. There are a lot of websites out where you can look up foods and you can look up calories of foods, and they are actually, people submit that data. It's not necessarily professionally done or professionally maintained. So the American Diabetes Association is always a good place to look. Like Paula said, if you have not had your diet redone in the last year, and most insurances will pay for that, when you visit your dietitian, she would calculate your calorie needs out, and she would give you a list of carbohydrate values of food. Food labels are always a good place to start, okay? And especially when you look at a food label, look at I'm going to take you all the way back there, if you could, Karen, to the picture of the food label. What is regulated in terms of what has to be regulated on a food label? I can put all the fancy words I want on the front of a food label, like sugar-free cookies, okay? I can put whatever I want on the front of that food label. But what is on that nutrition facts label that you're seeing up there now, that has some government regulation to it. So what you want to look at on there is the total carbohydrate, okay? And if you need a copy or you need to get a hold of someone, my telephone number is 258-2199 or 348-2199. We would be glad to help you get what it is that you need.
I would say yes, if that's how I told you to take it. Some of the medications last for a long period of time. It depends on the medication. There's many, many different ones out there. But I'm assuming that, and you can check with your pharmacist, but that would cover both meals. It actually gets into your bloodstream and stays in there. You're probably on a medication that actually doesn't make your body make more insulin, but just helps your cells respond to it better, and so therefore you don't have to take it with every single meal. Yeah.
Yeah.
Yep.
That would be common.
How are you testing to see if it's bringing it down? When do you test? Okay. To really look at the effect of your medication on what you're doing, one is the long term. You can look at trends, but the other thing you can look at is, like, what am I eating at a meal? Test it before a meal, test it 2 hours after a meal to see if you're getting adequate coverage or if you're eating the right amount of carbohydrates. That really gives you a better idea of what's going on.
I personally am a fan of home blood sugar testing because if someone is going to be testing that blood sugar at home, a lot of people think they do that and they write those numbers in that book so that they can take it to Dr. Biggs or their physician's office. But you learn a lot from checking that blood sugar machine. And I think checking your blood sugar is a very educational opportunity and a power tool for you. Just like Paula said earlier, what time do you test? A lot of times when I see someone, I'll go through their diet and they'll say, but what about spaghetti? Can I have spaghetti? And I'll say, well, what's your blood sugar 2 hours after you have spaghetti? Next time you have spaghetti, I suggest you check your blood sugar 2 hours after you eat. If it was too high, then the next time I suggest you eat 3/4 of the spaghetti you usually eat. Check your blood sugar 2 hours early. So besides that home blood glucose check, and keeping some detailed logs is a wonderful thing to take to your physician and a tool for them to have to help adjust your medicine. But when you're taking that blood sugar and using that home blood glucose monitor at home, whenever your blood sugar is a little higher than it usually runs or a little lower than it usually runs, you need to be asking yourself what was different that day. Several things affect our blood sugar: our exercise level, our food intake, and our medication. So if I woke up one day and my blood sugar was a lot higher than normal, I would be saying, what did you do different last night, Cindy, in terms of your exercise or your food intake or your medication? So the home blood glucose monitor is great. It's a great tool for your physician, but don't underestimate what you learn from keeping that home blood glucose record. When we would make a change, one is when it's consistent, okay? So if this is something that happens just like 1 or 2 mornings a week, I would go back to, like, did we eat something different or of that nature? If you're high every morning, then that's something you're gonna wanna bring to your doctor's attention, because it could be one of several things. It could be that we need to change the medication at supper time, okay, the night before, in order to make an impact on the morning blood glucose reading. I would, occasionally I would question someone and say, if you happen to be up in the middle of the night, you might check your blood sugar to see what it's doing in the night to make sure it's not going. Some people actually go too low in the night and actually rebound and then end up high in the morning. So I might have you do a couple, I'm not going to make you set your alarm for 2 a.m. every morning, but just a couple times a week, 1 week, to check it in the middle of the night to see what we're doing. And then the doctor would have to make a plan from there.
Usually your basal insulin or your long-acting insulin, we usually have patients take that at night is when we like to do that, just because the length of time that it's in your system and when it peaks about the time you're getting up, eating your meal, and that way it's throughout the day when you're eating that is in your system. The short-acting or mealtime insulins would be the ones that you would take before each meal. That's usually how we do it. I guess I'm a little bit confused how you kind of proposed your question there, which ones you were talking about.
If it's a trend and it's high every morning, that's when you're going to see that it's time to make a change. If you're doing your part and you're consistent, okay? If I'm consistent with what I eat, and yet I still run high at the same time every day, then it's sometimes time to look for a change, a medication change.
Exercise is definitely good for people with diabetes, but remember I said that the leading cause of death in diabetics is cardiovascular disease. So before you start an exercise program, it's important that you check with your physician and that you make sure that it is okay for you to start an exercise program on your own. They may want to do some tests for the heart to make sure first that there's not an underlying problem. We don't want to cause an issue and have you exercising when it's not safe. You want to be evaluated first to make sure it's safe, and then that you start out slow and easy and pay attention to how your body's doing.
I think part of that is it's not one individual high. I've seen some really high blood sugars. I work at a hospital. I've seen some really high blood sugars come in. It's really high over a period of time, okay? A high blood sugar is never good, and I've seen some, highs on the meter, and they don't read. But it's high blood sugar over a long period of time. Some of the initial studies with diabetes, like the diabetes control and complication trials, and some of those things showed that people who ran blood sugars over 150 for a 3-month period did have, over years they have had damage. So it's not just that one blood sugar on that one day that was high, it is years of running high where the damage occurs.
I think that's also why we talk about the A1C so much, is because it's an average. And to fine-tune your treatments, the other doctors will definitely want to know what your sugars are at certain times of the day. But it's kind of as the general health goes, it's easier to look at the situation from an A1C standpoint of how everything is going on average. Now, fine-tuning the medicines and stuff is much different than that, because they want to know, where's your sugars in the morning, in the evenings, and after meals, that sort of thing. So.
If I could offer one piece of advice, and as I look at some of the questions, a diary is a really good thing to keep when you're diabetic. Not only write down your blood glucose every time you take it, but if you keep a food diary, and then when your blood sugar is a little higher or a little lower, you can actually look back and say, well, what did I do last night? Even someone asked a question about stress. Sometimes even in that food diary, to write, something that was going on or a stressor in the day. If you keep some good detailed records, that can help you put kind of this puzzle that is diabetes together a little bit.